Good afternoon, everybody, and delighted you could all join us. This is a great opportunity to share the expertise and the knowledge from all of the different people that are on this panel. Our main speaker today is going to be Dr. Mary McKenna, who's the infection control specialist she's an assistant director of nursing with the National Antimicrobial Resistance and Infection Control Team and works with Professor Martin Cormacan. Thank you, Mary, for giving us your time again today. We have 4 members then on a panel that will answer the questions and answers section when we get to that. That is Dr. John O'Brien, who's a GP, a COVID advisor in primary care to the Chief Clinical Officer. We have Mr. Bernard O'Regan, who's the Head of Strategy and Planning with the HSE Disability Community Operations. We have Ms. Caroline Dench, who's a chartered psychologist and coordinator with the Callan Institute in St. John of God's. And we have Padraig McClune, a risk manager, and he's a quality patient safety manager with community operations. So we will get right on to the presentations now. Can I just start off by just thanking the AIIHPC for allowing us to host this on their platform. We really do appreciate their help in this. So I'll hand over to Dr. Mary McKenna.
Good afternoon. I hope you can all hear me all right. This is Mary McKenna. Minus the doctor, I have to say I'm an infection prevention and control nurse with the National AIIHPC team. I work with Professor Martin Cormacan and company in the Health Protection Surveillance Centre. And thank you, Mary, and for the Disability Services for this opportunity to share our views on the guidance that we have developed around prevention and control of COVID-19 in disability services. We appreciate this is a very challenging time for everybody, and we hope that some of the guidance today will be available, and it will be actually on the HPSC website in a larger educational module component for you all to use and access. So what I'm going to talk about today is based on the preliminary aspects of the module that we prepared, but I'm hoping to pitch it towards the residential services for disability. There's 4 components, so I will introduce COVID-19, discuss the preparedness, because if we're not prepared, we won't be able to deal with it when it hits us, as it has done in a lot of residential services in very challenging ways. And I'll also link you and I'll align you to the online resources so that you will be aware of the toolkit that you will be able to use going forward from today. So in terms of an introduction to COVID-19, many of you know now that it's a new respiratory virus belonging to the family of coronaviruses, which was first reported in China in December 2019. How it spreads is really the challenge for us all. It's dispersed in fluids from the respiratory tract of an infected individual. And you know, the attachment of this is by protein spikes through the mucosa of our respiratory tract. And the common ways that this will happen is by coughing and sneezing on another person, which is why you hear so much about the use of masks and prevention of transmission. And also, very importantly, the direct contact from contaminated surfaces. And that will include the hands, eyes, mouth and nose. So just bearing in mind that the contact from our hands in particular and contact with contaminated surfaces is a means of transmission. And as we all know, the World Health Organization declared this a pandemic globally in March 2020. In terms of exposure and the incubation period, it's most often 5 to 6 days but from developing symptoms, but it can also range from 1 to 14 days. And the period of infectivity, most people are most infectious around the time when they become symptomatic. But that depends on the severity of the symptoms and the stage of the illness that they're at. So higher levels of virus are detected in people with quite severe illness compared to the mild cases. So it is accepted that infection can spread from people before they develop symptoms, but we're just not clear yet how much this contributes to the overall spread of the virus. COVID-19 is generally detectable in respiratory secretions for up to 8 days in moderate cases and much longer in severe cases, so it may be 14 days when most people are not shedding the virus. Just going back to the contaminated surfaces, environmental contamination, we know from one study that survival depends on the type of the surface and the environmental conditions. Study findings, as I said, suggests that it can live in the absence of cleaning on plastic for up to 72 hours, steel up to 48 hours, and copper up to 8 hours. But the good news is that this virus is readily inactivated with most environmental products that we currently use in our healthcare facilities. In terms of signs and symptoms, most common symptoms include fever, which is often absent in older people and also in vulnerable individuals with underlying medical conditions. Presentation is often with a dry cough and shortness of breath, and I have outlined those here which you will get in the presentation. Fatigue is becoming more common, but there are unexplained changes in baseline conditions, so we shouldn't limit ourselves to the most common conditions or even indeed the less common conditions. So for example, an unexplained change in someone's baseline condition, if they are an underlying diabetic, for example, and their blood sugar is increasingly raised for no explained reason. And just to note that older people and other vulnerable individuals often present with non-classical symptoms. And as workers in the service, you will know your clients and your residents much better than anyone else. And clinical judgment certainly should be used when assessing and monitoring all the residents. But atypical things to look for is that sudden altered mental status, perhaps increased confusion or worsening of the condition that already exists in the lungs, loss of appetite and increase in falls. And one of the things that has become more commonly reported in such individuals is a loss of sense of taste and smell also. So to bear that all in mind when you're looking at the overall picture. And we know that residential settings, they're really like family households, which is where the greatest risk of transmission exists. People live in conditions where there's close proximity to others and gathering in social groups for activities. Some more than others may be dependent for activities of living and may have high care support needs. And many people are immunocompromised, have underlying medical conditions, including diabetes, asthma, COPD. So these are individuals who are increasingly, susceptible to transmission of the virus and to the severity of the illness. Many are frail and indeed cognitive physical impairment, and therefore unable to maintain good personal hygiene. The risk of serious illness does progress with age. We know from the morbidity and mortality data to date from 60 to 80 plus years of age. I suppose the stark reality is the consequences, and we're well aware from the daily reporting through the AIIHPC of the increased morbidity and mortality that prevails, and in particular in residential care settings, so to bear that in mind. So moving on to prevention of COVID-19 in a residential care facility, and this is really the building blocks that we need to have in place to prevent COVID-19 from, I suppose, transmitting as it does in some cases like a domino effect in our residential care facilities. I have a suggested number of, you could call it a checklist really in terms of preparedness and things that really should happen. And you really have to take this back to your own local service and identify, do we have these measures in place? So is there a nominated lead in our service for COVID-19? Is there someone to actually see that we are doing the suggested guided things that need to happen? For example, establishing surge capacity to manage an outbreak should one arise. So that's including identifying additional staff that could be called upon if it was necessary. And if at all possible, avoiding the use of staff who work in multiple other healthcare sites. That has become increasingly recognised. People are going to work in different facilities, and perhaps where there are outbreaks, they may even be coming home and congregating together and going again to facilities where there has been no exposure to COVID-19. So a way of mitigating against it. Having an up-to-date contact list, and this can be really important, and we don't think of it until a situation arises. Who do we contact for infection prevention control advice locally, and for public health advice on outbreak controls should this arise? And we need to be prepared for this. Considering also the feasibility, and I say feasibility of a plan for isolation where it's possible, or cohorting of residents. For example, if you were in a larger facility, can we separate those with symptoms who are suspected or confirmed with COVID to those who don't? And each ward or floor, particularly in the larger facility, should maybe plan for operating separately during an outbreak to reduce that potential transmission. So no more than the physical distancing, in the wider context of transmission in your facility, how you actually will separate and avoid transmission from occurring. And even looking at the basics around staff and equipment, having it dedicated for specific areas for shifts, again for COVID versus non-COVID, to try and give everybody the best opportunity to recover or to avoid transmission and exposure. In terms of even reviewing your daily activities and your workflow and your staff allocation, as I previously mentioned, so that we are actually trying to, in some way where possible, to create a division. And the basics are so important. We can forget about the basics when we see all the guidance around COVID, but ensuring we have supplies available. I know of one facility, and you know, it said to me afterwards in terms of lessons learned, they hadn't thought of tissues. Having alcohol-based hand rub, of course we have to risk assess the safety of where we place these, but having them available for staff, hand wipes for our residents, our cleaning products, including our disinfectants, and as I said earlier, it's coronavirus is and indeed COVID-19 is readily removable and inactivated with most of our household products. And having our personal protective equipment, we know that is a challenge, but have we ordered equipment? What do we have today? How long will we need it? How many people do we need it for? And we know as current guidance has been increased around the use of masks, etc., they will present challenges on the operational frontiers. Looking at your volunteer services that should be suspended in terms of things that were happening before, we're all living differently currently in this pandemic. So there's no service excluded from having to look at what's non-essential and identifying within them group activities and considering the need for discontinuation of any of those that is possible. And if they do continue, to try to keep the group small and with the same people consistently in each group is what we say, if they're deemed important and essential for your service to prevail. In terms of visiting across residential services, so I won't be prescriptive, but temporarily recommend a suspension, except, and this is important, you know, in terms of humanitarian grounds, specific circumstances such as the end of life, where it's really important that there is contact with family or next of kin, and ensuring that there is a process for updating residents and family around visiting arrangements, so that they are aware of why these measures are in place. In terms of your staff, increasing awareness of the COVID-19 and including what they should be doing if they develop symptoms, when and how they get tested. We know that that has become a factor for staff in all services now, and temperature checking before start and during work shifts. So is this process in place? Does our person who's designated to oversee all of this, are they ensuring that this is happening? And as I move on to ensuring all staff are trained, and you would say, oh, maybe more education, but so important, standard precautions. I can't reiterate it enough. If we don't have hand hygiene, the basics right, we're not on a winner from the start in preventing transmission. And indeed, respiratory hygiene, appropriate use of PPE. There's lots of PPE there. What do we need for today, and how do we appropriately use it? And in a minute, I'll come on to that. Having the procedures for safely donning and doffing your PPE and cleaning your environment and your equipment, so having those basics right. Just to say that all our guidance is up to date on the HPSC, as is public health guidance, and just to give you an example, this algorithm is worth a check every day or at least twice a week to make sure that we are in touch with what is the latest recommendation. So that was updated, I think, on the 22nd of April, which was last week. So I just wanted to briefly mention also the masks, because there have been a lot of conversations around masks in the last week, and the National Public Health Emergency Team introduced a recommendation on the routine use of surgical masks by healthcare workers in the context of pandemic. So wearing masks is designed to serve two purposes: reducing the droplet transmission of infection to the wearer, and also the risk of droplet transmission of infection to others. Surgical masks, you know, it's recommended across the HSE, as per the memo that was issued last week, should be worn by healthcare workers when providing care to patients within 2 metres. And we take that within healthcare as residents of long-term care facilities also. So it's regardless of the COVID-19 status of the patient. Surgical masks, it's recommended they're worn by all healthcare workers for all encounters of 15 minutes or more with other healthcare workers in the workplace where a distance of 2 metres cannot be maintained. Now you may say, well, one example could be going for my break, for my coffee break, but you're obviously not going to wear a mask when you're having a cup of coffee anyway. Important thing is to know that you don't pull the mask up and down on your face, that once you remove it, you discard it. You don't touch the front of your mask. Touching the front of your mask and perhaps touching other parts of your eyes or nose will increase the potential for self-transmission of the virus. Hand hygiene, respiratory etiquette and social distancing remain really key to preventing the COVID-19 transmission, and always bear that in mind. In terms of your residents, ensuring that communication is kept very, very prompt, as I said earlier, assisting them where possible and practical to clean their hands, promote cough etiquette, and to report any new illness. Yes, there's a recommendation to monitor residents twice daily, but actually asking the residents how they're feeling today and getting a sense of their well-being as they see it. As I said earlier, keeping family informed, encouraging ways to keep everybody in contact virtually, and assisting family if they do need to come to spend time with a relative, for example, in the event of end-of-life circumstances, that they can use the PPE and they know how to protect themselves and feel as safe as possible. And we know around the cocooning that the measures to implement them, I'm not going to go into all the detail for the purposes of time in this webinar, but to encourage and support residents to maintain that distance, staying away face-to-face from individuals as much as possible, and looking at ways to do that. And our education programme, which we will be aligned to, will explain that in more detail. So just 1 or 2 slides as I conclude in managing the COVID outbreak in a residential service. If it's one individual, what do I do today? You know, this is really a take-home message, that if we're not sure what to do, you need to isolate the residents, if possible, in your single room with toilet facilities, and implement the droplet and contact precautions, and get a GP involved and arrange for the nasopharyngeal swab testing. Letting public health know and informing family members of the situation is very important. If this is a staff member in your service, identifying the staff member, that they go off duty, and if there's a delay in time to leave, that they actually leave the area where residents are into a separate area until they go off duty. And immediately getting that in-house meeting going with your other staff, identifying, is there anybody else symptomatic here? Has there been an increase in staff absenteeism? And making that connection with your public health or community infection prevention control also, for further guidance to progress with this. And there's a lot of guidance out there now and available on the HPSE website also, and identifying your residents and staff who are in close contact. And again, your algorithm will guide you through the key essentials for that. Practically separating into single rooms or cohorting. And cohorting is where you have a number of individuals that may go into one zone or area. It may be a multi-bedded area, and that can be challenging. It may mean reducing bed numbers and having only residents with confirmed COVID cohorted together, and maintaining your physical distance and bed space as much as possible. But having some essentials in place, clear signage, privacy curtains, keeping your equipment dedicated again, ensuring there's no crossover of staff. But it's really putting what we had in preparedness into reality here, and restricting your area so that staff actually are separated as much as possible, and indeed residents. And I'm just going to finish, because I know I'm in the interest of time. But just to talk about personal protective equipment, you know, wearing what fits you. There's no point in wearing anything that's too big, but remembering hand hygiene is really important at all times. And PPE may be worn in 2 situations. For an individual episode of care, so if you're going into an isolation room or a facility with one person, it may be a hostile environment, that you will wear your PPE and afterwards you remove it. However, if you're looking after a number of individuals in a cohorted services, that your mask and your PPE may be worn with the exception of your gloves, which is removed for hand hygiene. So there is no time span for the mask in this situation. We would call it sessional use of PPE. But I just wanted to throw that to your attention. And just to say there's different contexts, because you may say, well, I'm not a healthcare worker, I'm a social care worker. There are different levels of contact regardless of your role. So, you know, you have to take that and say, what is my level of contact for my level of risk of transmitting or acquiring a COVID from a positive or suspected individual. So we have a number of examples which I have on the slides, which you can go through afterwards, as I will be sharing them, as we will do and have on our education program. But taking a swab versus helping to feed somebody or assisting in the kitchen with cooking or other activities, you have to deem what is essential for the quality of life of the individual that you're working with. But those are low contact examples where, you know, a plastic apron and a use of gloves and a surgical face mask and eye protection as you risk assess the need for it. Whereas in high contact activities, there is a greater level for a long sleeve gown and a disposable surgical face mask. So that may be in terms of changing incontinence wear, assisting with toileting or bathing or showering, and care activities where splashes and sprays are more anticipated than in the low level. And just note that we generally don't have several aerosol generating procedures which are airborne in disability services. Examples there including your sputum induction or high flow nasal oxygen therapy. A respirator mask is used then in terms of a surgical mask, because that comes up even from services outside of the hospital in terms of the use of the mask. Your surgical mask is your standard mask requirement other than for airborne precautions, and your aerosol generating procedures are carried in a single room away from other residents and staff. And to bear in mind one thing, that administration of nebulized medication is not an aerosol generating procedure with an increased risk of infection. That is a very common query for a fairly common procedure in a number of services. And just say for cleaning as well, that it can happen when there's a resident present. Your plastic apron and your gloves and your mask prevails. And it's the case of having your zone, and I've added this to the slide, you can look at it afterwards, but just in terms of putting on your PPE in a separate area to removing. And we have some guidance around this, and you will get onto Martin Cormican's video on the HPSC website, you may use that. But bearing in mind having a separate area for putting on PPE and for taking it off. And cleaning, as I said, it's coronavirus, COVID-19, it is readily inactivated with most bleaches and disinfectants. And we have some guidance on our education program around that. But just bear in mind that use the products that are supplied by your employers or that are available. So do look and see what are we using. And having our staff trained in our PPE, if they're cleaning staff, in our current circumstances in healthcare environments, what we would say particular focus to your close contact surfaces. And indeed, just your terminal cleaning always perform it after a resident has vacated the room. And we have a number of steps to that which we'll be sharing on this slide set. And in conclusion, managing your waste, laundry and crockery, just to say the crockery and cutlery may be washed as normal through your dishwasher. Your waste can be discarded as healthcare risk waste, but in areas where you do not have healthcare risk waste providers, that double bag the waste in household bags, secure the bag and leave for 72 hours before collection. Again, your laundry should be handled as infectious laundry and it can be washed in the hottest cycle. I'm going to just say for uniforms that your uniform, can't be washed. We don't recommend your alginate bags in your home washing machines, but just uniforms are not PPE. They are your protective clothing, whatever it is that you wear, whether it's a uniform or your own self-mufti, but it can be washed in your own machine, and we have recommendations around that on the website. And in terms of care of the dying, that pastoral care shouldn't be restricted. This is a really important time for people, and a lot of sensitivity needs to be exercised, but actually guiding people through that process, and we have specific guidance around that also. So in terms of monitoring your progress, Public health are going to be in touch with you at all times. You should be in touch with them, and they will declare your outbreak open and closed. Just in conclusion, online resources and links for preparedness. We will be sharing this on the HPSC website in a wider programme, but there's a link to a toolkit of all the resources and links for residential care facilities. And we would advise you to follow the videos, follow the links on donning and doffing of PPE and hand hygiene, chain of infection, and hopefully it'll support you on the way with the great work and the challenges that you're meeting currently. So thank you very much, and I will hand you back now to Marie.
Hello, thank you very much for that, Mary. That was very, very informative, and I think answered some of the questions that actually were coming in on the screen. It also raised a few additional ones, but we'll go through the question and answer period now. If anybody has additional questions, just use the Q&A button down there in the bottom. Some of the questions that were sent in during registration, we have those so prepared. So I'm going to go over to Bernard first of all. One of the questions that came in, Bernard, was in residential facilities that are social care led, so that they don't have access to nurses. I suppose just how do they know when the people that they're supporting are deteriorating, when to escalate their treatment, etc.
Okay, thanks, Mary. So there are lots of guidances that are available on the HSE website and on some of the links that Mary referred to in her presentation, and that are included on the links at the bottom of her slides. And if you go there, you'll get links to everything that you might need. There's lots of work being done to develop guidances. These kinds of webinars are very useful in terms of keeping people informed. Lots of these, as Kathy mentioned earlier, are being recorded and are available to people even outside of the live event. But if anybody has any concerns or anxiety in relation to an individual they're supporting, they always have the avenue of contacting their GP and getting advice from their GP on the best care of the person that they're supporting.
Thanks very much, Bernard. And just following on from that, could I bring John in on this, please? Because John, you're a GP. One of the questions that was asked is, where can clinical support be sourced to support the ongoing monitoring of a resident, and should they need to be seen by a GP? Is there a care pathway for that?
Okay. Well, I suppose the thing to say about COVID is that it's a new infection, and we're learning things about it as we go along, and the criteria for making the diagnosis at the beginning were much tighter than they are now. We're learning that we need to be spreading our net considerably wider. Those who work in residential settings know their clients, and they know them well, and oftentimes over many years. And having that baseline knowledge of the person is absolutely invaluable, because you will know when your client is disimproving. You may not know why they're disimproving, but you know that they are disimproving. In terms of seeking extra advice, well, it will depend on the setting that you're in. Long-term care is sometimes in congregated settings where there are large enough numbers of people, and sometimes it's out in individual houses in the community, which might have maybe 4 people in it with a social care worker keeping an eye on things. I think that in the bigger facilities, there will be directors of nursing and assistant directors of nursing. So the chain of command will be there, and there will be a lot of backup support there. Maybe not quite so much for social care workers out in the community, although generally speaking, there is nursing overview of what they're doing as well. So whatever you did before for somebody who was unwell, well, you're not going to do that any differently now. So if it's such a thing that previously you passed it up the line of command to see, you know, should we call the doctor for this? Well, that's exactly what you do. A GP is there to make an evaluation. Lots of the evaluations that are being done at the moment are being done over the phone or perhaps through video links, but not all, because it won't always be appropriate to do it that way. But I think that if you have a good relationship with the GP, then the GP knows what you're talking about, and you know what the GP is talking about, and it works very well. The difficulty arises where, and it has happened in some of the instances where there those connections aren't as robust as maybe they might have been, I think it behoves us all to kind of to sharpen them up and strengthen them. But essentially, do what you always did: contact the GP.
Thanks very much, John. And can I just ask you a follow-up question on that? Will the community assessment hub doctors be available to see residents that are in intellectual disability?
Okay, so the function of the community assessment hubs is to try to take some of the COVID out of the general practices, to allow the general practices then to open up for the usual business of care. They are there to assist the GPs in the decision as to whether or not this person needs to go on to hospital or not. GPs would make the first evaluation, and then they would refer on. Specifically, long-term residential care facilities are not going to be sent to the hub. However, those houses that I mentioned previously, you know, where there might be 4 people in a house, that's very much like an ordinary home. And under those circumstances, they will probably follow down that pathway. There will be instances where maybe there's, which is it? Is it one or is it the other? But I think that generally speaking, people will know. And mostly those instances that are managed by social care workers, they will generally speaking be out in houses and will be part of the community anyway. So it's a community assessment hub.
Thank you very much, John. Mary, I'm actually going to go back to you for this next one because there's a bit of confusion out there around the temperature checks. First of all, is it for staff and residents, or is it just for staff? And is it supposed to be done once a day or twice a day?
Yeah, well, as far as we're aware through the occupational health guidance, also in addition to the monitoring of residents, the recommendation is twice daily monitoring of residents, and also for staff. So a staff member should be checked coming on duty. They should be reporting their temperature, and also on one further occasion whilst they're on duty is the current guidance, as I understand it, which is in the there's wider information available on the AIIHPC website around that. But bearing in mind that just in terms of residents, the temperature is one thing, but not all residents, and John alluded to it there. You know your own clients and your own residents, and you know if they're having an off day. And can I just say on that, Mary, as well, in terms of monitoring, some people are actually have reported, you know, in particular staff, if somebody is positive or negative, you know, do they have if they're not positive, you know, it means that it's not detected on the swab on the day. It does not mean that respiratory, you know, symptoms should be considered that we're not. This is not like norovirus in the hospital environment where it's not detected. You know, that, you know, there is a percentage of negatives that are positive. So there is a degree of that. So it's just to bear that in mind also in the overall picture of the monitoring.
Thanks very much, Mary. The surgical masks, the guidance on the surgical masks that was issued last week has caused quite a bit of alarm, some confusion out there. So just a couple of questions that are coming in around that. One of them is there's a bit of confusion about the 15 minutes. So a couple of people are asking, you know, is it like staff are working in a residential service with a number of people who are COVID negative? Can they keep their mask on between people if they're going from task, if each task is 15 minutes? So I think there's a bit of confusion about the 15 minutes pertaining to just staff to staff as opposed to staff to residents. So would you be able to just clarify that?
Yes, and I suppose, well, I'll clarify it as best as possible. As you're aware, this was a recommendation that came down from the National Public Health Emergency Team to the HSE, and the surgical masks to be worn by healthcare workers when providing care to patients within 2 meters of a patient, regardless of the COVID status, and for healthcare workers for all encounters with other healthcare workers. And it is generated quite a lot of discussion about practical implementation. I would say that the 15 minutes is given as a sort of a guideline around, you know, a time frame. So in terms of the queries, I know that the expert advisory group is further guidance for specific scenarios will be available, and perhaps we can introduce these on the question and answer chat box after this webinar, Mary.
Okay, yeah.
I would say, like, in a typical situation, a healthcare worker is looking after one individual, a client, and they are finished their care. If this is in a congregated setting and they're going on to another client in the same facility, there's no reason why they should take the same mask off, providing they take off their gloves and clean their hands. That's a really important bit. It's the immediate contact.
Yeah.
And use of the mask. If you're wearing it for longer than 50 minutes, you're not touching it with your hands, particularly the front of it. That's crucial. Or pulling it up and down and saying, well, I'll pull it off for now. Once you no longer, once you need to remove the mask, you take it off completely. You clean your hands. I mightn't answer all the queries because I appreciate they are very, very broad, and it's challenging for certain circumstances, and we're working our way through them to implement this guidance from the National Public Health Emergency Team as much as possible, and it certainly has prompted a lot of very genuine queries for practical implementation.
Yeah, absolutely. One question that came in was about the idea of using homemade or washable masks. What's the advice on that?
Again, the masks were always designed in our world of infection prevention and control as a single-use item, and again, it's around the conditions that can be used, to reprocess masks. And I understand that is actually being looked at with the expert advisory groups. This is not a cop-out answer, but we would hope that further robust guidance would be issued around that. Say, it slightly went against the grain of infection control initially, but the reality of the availability of masks, we have to be practical. This is a pandemic like we never had before. So I would hope that certainly that there will be some additional guidance beyond myself and outside of this webinar, and we maybe should align that with the chat box.
Yeah. And I think you've answered this already when you talked about using a pragmatic approach and people knowing their clients best. There was a question that came in about, is there a derogation for situations where a person supported will not be able to tolerate a staff member wearing a mask? But I think you would have said that you take a pragmatic approach to that. Is that my understanding?
Yes, the recommendations for the masks and the PPE stands. But you have to balance infection prevention and control with other scenarios and in the quality of life. For example, if it's quite distressing for an individual, that what can we do differently? We're all living very differently at the moment, so we have to actually look at what we can do on a day-to-day basis with the type of work that we are delivering, the type of care we're delivering, the assistance we're providing. But bearing in mind, how do we protect individuals and protect ourselves? That's the bottom line. So there's no prescription around each one of these, but it's taken that risk assessment approach and keeping their standard precautions. I can't say it enough. The hand hygiene and respiratory etiquette, keeping that, and your clean hands, clean environment, clean equipment, respiratory hygiene. And then, your approach around the day-to-day scenarios, because I appreciate it comes up, and it may well come up in a question around taking a swab from an individual. How do you cross the line to do that safely, that you're not, going beyond and actually creating other emergency situations for individuals.
Yeah.
Risk assessment, Mary, was what I would say.
Great. Thanks, Mary. Thank you. Bernard, can I just come to you, because one of the questions we got there was what constitutes a healthcare setting in that particular guidance that was issued, and the question was, did it cover these three areas: residential settings, group homes for people with disabilities, overnight full-time service provision in a person's own home, so individualized services, and community support, so in a person's own home, things like personal assistance. Can you just tell us if it covers all of those particular settings?
Okay, so the guidance does cover all of those settings. I think if you go back to one of the points that Mary made earlier on about why these measures were introduced, they're partly to protect the person wearing the mask. The second part is to protect the person being supported. So when you take those two things together, clearly in relation to residential services, whether they're community group homes or more congregate settings, whether you're supporting a person in their own home, either overnight or indeed for PA or home support type services, then the mask should be worn. However, I think it's also important that people look at the guidance clearly. It says if you're working within 2 meters of the person. So there may be instances where support is being provided that don't bring the staff member within 2 meters of the person, and they need to use the guidance in that way. It isn't about, you know, I think there's a bit of judgment needed in terms of how that is applied. But certainly the caution should be there in all settings in the best interest of the staff member providing the support and the person being supported.
Thank you very much, Bernard. John, can I just come back to you in terms of the learnings from other services around the prevention, because this webinar is very much about prevention and preparedness, and what we're trying to do is prevent, if at all possible, COVID from coming in to a particular home in the community, as you said, and there's lots of different settings for intellectual disabilities. But is there learning we can take from any of the other sectors in this?
You're muted, John.
Great. There are learnings, of course. I suppose what we need to bear in mind is that it isn't just one pandemic. There's a pandemic in the wider community, there's a pandemic amongst the healthcare workers, and there's a pandemic within the residential long-term facilities as well. And it's how all of that interacts. A lot of the workers who work in long-term care facilities, at least in the early stages, were working in different centres, and Mary alluded to that, and it led to a good deal of transfer from one area to another. One of the things that Mary alluded to as well is this idea of cohorting patients, or even having a COVID portion of the centre and a non-COVID portion, and not having the same workers operating in the 2 centres to kind of divide the workers. The other thing to remember is that a lot of healthcare workers are either living together or related to each other, maybe married to each other, and the risks for a transfer across from one to the other are aggravated by that. I think that there's an awareness, we need to have an awareness of all of these features in terms of trying to keep it out. And I know with regard to the unit that I looked after myself, it was a husband and wife that kind of, one brought it in and then the other brought it to another unit, you know, so that sort of thing it does happen. I think that preparedness, Mary went into preparedness quite well there, I thought, and I think it's all about being prepared, knowing where you're going to isolate people, knowing how you might go about cohorting. How would you divide the staff? Have you enough staff? Have you extra staff? Because one of the other things that we're learning is that as people get infected, they run out of staff very quickly, and the next thing is that you have care facilities that are in a lot of trouble. So I think that training is really important. One of the surefire ways, well, there's a couple of surefire ways of getting this. Mary just alluded to it, it's droplet spread. So if somebody coughs on you, or if they cough onto a surface, you either get it from the direct cough, or you get it by transmitting it from the surface to your mucous membrane, which is your mouth, your nose, your eyes. It's to know all of that, and to know when you're doing your donning and your doffing that you must do it very carefully, that you never touch it's the front part of your body is where the virus is. So it's either the front of the mask or the front of the PPE. So don't go touching those places. Careful hand hygiene. Look up what's on the HPSC. It's really, really good material. Very clear, and lots of it in video format, so that you cannot but know. When you're doing things, a buddy. So if you're donning and doffing, it's a good idea to have somebody looking at what you're doing and seeing what mistakes you're making. The other thing is that in a unit, maybe it might be useful to have somebody going around giving out to people for touching their face, or for not cleaning that surface or whatever. Preferably the most junior person in the place, so they get used to power. They would be some of the learnings, and there are many, many other learnings to be had, and they're feeding their way into the guidelines. So I think that go and have a look at what's on the HPSC. That's my take-home message. know it backwards. It's all in there for you.
Right. Thank you very much, John. Thank you.
Oh.
Padraig, I'm going to bring you in here for a second, just with your risk management background. A number of speakers have spoken about this idea of risk assessing. And I suppose one of the things we really struggle with in centres where we're supporting people with disabilities is that we're trying to maintain a home-like environment that includes the protective measures, but we also want to keep that as that person's home. And there's cross-infection risks in so many potential rooms within those home settings, like bedrooms and bathrooms and kitchens and gardens. Can you just give people an idea of what they should be assessing in terms of a risk assessment?
I think we'll just hark back, Mary, to what John hark back is. There's no point trying to come up with a risk plan or an assessment when somebody or one of the people you're supporting actually tests positive or starts displaying symptoms. In advance of that, what I would suggest is that people risk assess the setting that they're in, look at the daily routines. Are there ways that they can separate the people they support during times of close contact, like perhaps at meal times and so on. At the routine, and they separate people out as best they can. Then, you're not going to be in a position where you can start taking down curtains and have disposable curtains. It isn't going to happen. So the key really around risk assessment is preparedness. Are you aware of the recommendations in the guidelines, the AIIHPC, HSE guidelines? Familiarise yourself with those and minimise the contact within the house as best you can. Again, the advice on the masks is it has to be followed as well. And I understand completely the difficulty in supporting certain people who may not be able to tolerate a mask, may be afraid of wearing a mask. All of those individual risk assessments need to take place as well, because there may be ways of minimising the risk, there may be ways of reducing the risk to those people in terms of patient and isolation. And distancing, but really the main thing is about preparedness.
Thank you very much, Bernard. Sorry, Padraig, my apologies. I'm going to go on to Caroline now, because we're going to look a little bit about residents' rights, because a lot of staff in this area would have concern that residents' rights could in some way be undermined, in particular when it comes to things like testing people, having to cohort people, putting people in isolation and the like. Caroline, would you be able to just give us some advice on those areas, please?
Yeah, thanks, Mary. I suppose when we think about testing, we have a lovely document which is on the HSE website regarding the role of consent for testing. So we can't impose a test on anybody without their consent. There are some lovely resources available to help us think about that, and also to help us think about the symptoms that the person is presenting with in the context of self-isolation, and being able to safely relate with the person who is symptomatic and who may have refused a test because maybe they're scared, confused, they don't understand what has actually been offered to them. So in the context of what we'd be suggesting is, do look at all the resources on the HSE website, but also do think about helping a person get used to the idea of having a test. So even seeing and touching some of the PPE, even actually looking and seeing a swab, even being placed near a person's mouth if it's not their own. So you can actually help build up a person's, I suppose, tolerance and ability to actually participate and engage with a test. I think the other thing that's really important to note is that a test is a moment in time. So the person may test negative today, but in 2 or 3 days later, that test could bring back a very significant change for the person. So really the message that we're giving is to maintain this whole concept of safe relating in the context of self-isolation and in the context of being with others where we have restrictions. The other document which is really useful is the HSE social distancing document within the work environment. And that has a number of indicators that are really nice to help us kind of think about how we're entering and exiting an environment, how we are when we're in an environment, how we're actually maintaining the clean environment, the clean hands, the chain of infection protocols. So they're really important. I think the second thing, just to touch on there, is, well, what do we do if a right has to be restricted? So if we're very mindful that actually we're constantly redirecting the person back to their bedroom. So the person is seeking to leave the bedroom. And what do we do with that? And we may not be using any force or any kind of coercion with that, but it's a gentle hand on the shoulder, back to the elbow, and say, come with me and we'll go back in here. What we would be suggesting is that you document this, that you are making a decision to redirect the person back to their room. And you also then think about, what is it about this person that's trying to let you know, why do they need to leave the room? What are they seeking, or what are they hearing outside of the bedroom? So what is actually enticing them outside of the room? And can we actually think about that with them? Because people that we're supporting do not mean to be difficult. They don't mean to actually make our work any harder than what it already is. So they're desperately trying to communicate something to us. So how do we think about it in a way that is the person's voice? And we then think about, I wonder, can we support this person to be outside of their room safely? And what would that look like? So again, we don't have a recipe book. We can't actually say, do this at all times. But I think the pandemic, the document on decision making and ethical decision makings in a pandemic is really nice, because it highlights some really nice values around inclusiveness, transparency, proportionality, and of course the voice of the person, and that we're always person-centered in the context of safe relating with everybody that we're actually living with and supporting at the moment.
Thank you very much, Caroline. There's a couple of questions that have come in just during the webinar this afternoon, in particular around the disposal of PPE. So Mary, I might bring you in here again. A couple of questions. One is, do you still need to double bag the likes of masks if you're in an area, in a house, for example, with no suspected or COVID positive clients? And the next one then is around the uniforms. So, and it's not necessarily uniforms, as you said, people may wear their own clothes to work, but is it recommended then that people are changing those clothes before they leave the setting, going home, and then washing those in their own washers and dryers at home?
Thanks very much, Mary, and for the participants for their very valuable questions. And I would say now I'll start with the uniforms. So whether it's your mufti or whether it's a specific garment that you wear for your work in uniform format, it is good practice to change out of your uniform after your work, because you have been working, if you're working with clients or residents or individuals where there is a high exposure of contamination, so that you're not getting into your car with your uniform on and you feel that you're exposing the fabric. So yes, change out of your uniform before you leave work is very good practice to someone who has suggested that that's what they're doing. And you may wash it at home in your own washing machine. And I suppose just to reiterate what I said earlier, that a uniform is, regardless of if it looks like a scrub in some situations, that it is not PPE, it's your personal garments that you're wearing. In relation to, sorry Mari, can you just remind me what the second question was there? Or the first part of it that I... The
first part was about the double bagging.
The double, sorry, about the waste, yes.
Yeah, most houses, yeah, most houses.
Okay, so in normal circumstances, waste gets disposed of in household waste in houses, and if transmission-based precautions in community residential setting will apply, where there is an arrangement currently in place for the clinical healthcare risk waste, okay? In the situation of a COVID positive, it is recommended that the waste is double bagged in household if you do not have access to a healthcare risk waste provider, okay? So it's what you normally have that is in place in COVID situations. I'm not aware of a standard precaution that is now saying that routinely we discard all of our masks and gowns into into regular waste, but we are working in pandemic times, so we have put that forward to the expert advisory group for clarification. But currently we're saying in the facilities where there is no healthcare waste provision of service, that you are double bagging suspected or confirmed COVID. With the increase of the masks, you will appreciate, and I had sight of a document this morning that's going to clarify further what we're going to do with all of our healthcare, all of our PPE. Currently, we've been wearing it on the premise that was suspected or confirmed situation. Now we're wearing it for all situations. So that note of guidance hopefully will be available this afternoon, and perhaps we can align it to the Q&A, Mari, if that's possible, and put the final recommendation onto that.
That sounds fabulous. Unfortunately, technology has let Marie down and she has disappeared from the webinar, but we are getting quite close to the end anyway. So I wonder, is there any questions that any of the rest of the panel would like to touch on that have come from the Q&A?
I suppose just to say again that, you know, this pandemic, whilst we may come out of the immediate, as some people describe, a lockdown phase, that as time goes on, and we are aware that within the next week and in the coming weeks, certain restrictions may be restricted or may be lifted or reviewed, and it's important to bear in mind that this by no means means the end of the measures that we're currently trying to implement and live with. We're going to be living with COVID-19 for a long time, certainly until the lifetime of a vaccine becomes very readily available, not just available, but readily available to the population around us. So I think it's about trying to implement ways that we can all live practically and apply common sense to the measures that are being recommended, so that there's a quality of life for our residents, our clients, and for our staff who are delivering the care. But we are going to have to be quite careful around our infection prevention and control measures going forward. But there's a lot of information and guidance available. And on a final note, just to say that we are delivering a webinar on Friday for the primary care for the home setting, which I gather from listening to the webinar, there may be some services who may be interested in actually going into home settings as opposed to into residential facilities. And we will have, as I said, an education module available for all residential care providers, which you can use the slide sets, any of the participants can take them and share them with your staff. And I think it was John who earlier said, you know, the information is there, it's a case of accessing it, but do people really understand how things are today? But thank you for that.
I think Marie has maybe just rejoined, is that right?
Yes, I have. Sorry about that. That is the technology. Yes, I'm able to. I'm just joined in by telephone there. Just one of the other questions that has been coming up has been if a person who's being supported with a disability needs to go to the hospital for a non-COVID related illness and then is coming back to the home that they live in, does there need to be some preparedness strategies put in place in that home before that person comes back? And possibly Mary maybe to answer that.
Okay, I'll do my best. There's a bit of an echo on your phone, Mari, but I'll try my best.
Oh, sorry.
You're saying for transfer of somebody, yes, if somebody needs to go to hospital and it's not COVID, the hospital service is still very important. So obviously you're going to get in contact with your GP, and if so, that the hospital will make arrangements for the care that needs to be provided. And in terms of transfer back, yes, it is important to be aware that this individual may have been exposed in a hospital environment, and their return will require suspected situation for 14 days. So they are going to come back on contact and droplet precautions following the healthcare environment that they have been exposed to. And in terms of even within the environment, they may actually, and it has happened where vulnerable individuals have actually, they have been exposed and they have been detected with COVID-19 during their stay there. And I suppose the current guidance would say around that when they're coming back, that before they leave the hospital environment, so they may have went to hospital for another reason and is coming back with having been exposed to COVID-19 and they've been a confirmed positive. The current guidance from the expert advisory group, and we checked that last week, is that they do not return until they are 5 days symptom free with they have 2 nasopharyngeal swabs that are not detected, and those are 24 hours apart. Again, your transfer back to your facility can be a challenge, a isolation room if possible, and indeed, if it is somebody that has fully recovered, that they have their, not negative, should I say, but not detected in their nasopharyngeal swabs. I think that was your question, Mary, from what I was picking up, but if anything further, happy to answer it.
No, that is exactly what it was. It was just, what kind of preparedness do they need to have back before the person came back from the hospital. Okay, I think our time is up actually. And that what we're going to do is there are some questions that we didn't get a chance to answer, or that we want to just research ourselves and come back to you on. So we will have a list of a Q&A that we will put up on the website. The slides will also be available on the website. And just to let you know as well that there are quite a few guidance documents that relate very much to the types of things we were talking about today. And they're going to be on the partner resources page of the website. So if anybody needs those, just send me an email and I can make sure that you get the link for those resources. But it's just really for me to thank Mary McKenna. Thank you so much for your time today. And Dr. John O'Brien, Bernard O'Regan, Caroline Dench and Patrick McClune, thank you all for your time, and thanks to everybody for tuning in.